Where you are in the world. Good morning, good night, good late evening, early morning. I have Fred and Heather with us today. Fred Rowe is our actually works with us. Uh, as he began working with us, he started talking about his own case. And here's the question: you show up in the ER, you've got chest pain. The doctor says, "You know what? I think we need to do a bypass." And that's a surprise. Now, what do you do? How do you make that choice? So that's what we're going to be talking about. That sort of decision hits people every day in this country, and the vast majority of folks are not that prepared. Before we go further, Fred, why don't you introduce yourself? And then Heather, I'd like for you to introduce yourself.
My name is Fred Rowe. You're going to hear my story of kind of how I eventually had a heart event, and we'll talk about that. And kind of probably the interesting background here is that I've been in the medical field for 40 years, trained as a psychologist. I worked in the wellness business. I was always, for 40 years, been involved in preventive medicine. And it wasn't until I landed in emergency that I had any clue about how to ask the right questions and to be able to make what I perceived as a monumental decision, quadruple bypass surgery. And I was shocked I was there to begin with. So, I'm probably in somewhat of an interesting case that I've been working with doctors for 40 years. I've been grilling them. So I was never intimidated by that because I had so much experience in the field. And I was on the prevention side. And still I landed in emergency and had almost no clue how to question my doctor. So that's probably the background I have that's most relevant to what we're talking today. I do work with PrevMed, so it is interesting. I talk to a lot of patients coming in. Sometimes I take some initial calls just to kind of get a feel for what our patients need. And I hear my story a lot. I mean, a couple days ago, guy said, I'm meeting Tuesday with my cardiologist, and he's recommended triple bypass surgery for me on Thursday. What do I do? Okay. A woman yesterday I talked to, I've had 3 strokes. I had one last Friday. What risk am I at? My doctor said this. So, I mean, I think my story is common, and maybe the background of the patients we have is not so common to mine, but still, it's a difficult time when your wife is freaking out, the pastor shows up, and it's like, does he know something I don't know? And anyway, that's kind of what we want to talk about today.
And I'm Heather Darwin. I'm a nurse practitioner with PrevMed and have been working with the crew and Dr. Brewer since May. So I'm looking forward to continue to work with PrevMed and meeting more patients.
Very good. So let's go ahead and get started. If you're new to this channel, if you haven't seen the sort of stuff that we cover, we're all about helping people prevent heart attacks, strokes, the things that Fred's talking about today, and not having to end up in the ER. Recent information that we've covered: vegan diet. Diet is the number one thing that you can't outrun a diet. You can't out supplement a diet. You can't out prescribe a diet. So there's a whole bunch of emotion about diet. Unfortunately, there's not a whole lot of clear facts about diet. So it's one of the biggest things in the preventive medicine community that people just love to debate and just get into big fights about. And one of the things that you'll see is that we have a position where, look, we have vegans, we have vegetarians, we have paleos, folks on paleo, we have carnivores. All of those are ways of achieving um, a healthy state, but it's not really quite so much an issue of where the sources of your macronutrients come from. Macronutrients are important. Here's the issue. By the time we're age 60, the majority of us cannot metabolize carbs. And if you're one of those people who cannot metabolize carbs, you need to be aware of it, because having blood sugars 140 and above, hour after hour after hour, burns the inside of your arteries. When it burns the inside of your arteries, whatever level your LDL, your cholesterol is, it can seep through those linings of the arteries. That causes plaque. Your immune system recognizes that plaque, realizes that that plaque really shouldn't be here, so it starts to attack it. It does what your immune system's supposed to do. And here's where the problem is, and here's why Fred's doctors could not predict a heart attack. It's not that the plaque grows and grows and grows like hair in a drain until it stops the blood flow. If that were the case, we could predict a heart attack. We could predict how, where, and when it's going to happen. But that's not how this works. It's very unfortunate, but it is what it is. It's a thing called inflammation. It's what I was talking about a minute ago. If our immune system sees plaque and starts to attack it, it can soften that plaque. And that soft liquid plaque, if it comes back into the artery and touches the blood, it can cause a clot. That's exactly what happened with Tim Russert. One of you, Fred, you may know, you're my age and older. So Tim Russert, was it Meet the Press or Face the Nation?
I think he was the Meet the Press guy.
He was the longest running MC for it. He was having some problems. His waist size was going beyond 36, 38 inches. He was having problems with his blood pressure. It was like April. And he went to his doc and he said, I'm having some challenges. You know what? Why don't we get a stress test and just make sure I'm not going to have a heart attack? So he and his doctor got a stress test. He passed it. So he thought he was fine. Went on vacation in Italy with his family, came back home. He was recording a voiceover for the show. It was, I think it was Saturday and the show was Sunday. The producer walked in, he looked up and he said, "What's happening?" Turned back to the computer, had a heart attack and died just a few weeks later. So he's one of those people, and they're all over, where they passed a stress test just fine, but still had a heart attack. So this is a little bit more complicated than what most people think. That doesn't mean that we can't prevent them. It's crystal clear that we can prevent them. We just need to do things a little bit differently. So as Fred pointed out, and he's going to tell in his story today, how do you put all that together with the experience of, oh, you know what? I got chest pain. I'm in the ER. What do I do? So back to previous topics, what your doctor won't tell you about calcified plaque. I'm not going to go into details on that. Reversing plaque is always a popular subject for us. And that is, I mentioned we can predict heart attacks. We can prevent heart attacks. It's not with stents. It's not with bypass. It's by achieving metabolic health. Fred, you want to mention the conference event?
Yeah, for sure. We are having a weekend immersion, sort of a jumpstart for your heart health program on December 1st and 2nd in St. Pete, Tampa. and you get rare occasion of Dr. Brewer for how many hours?
Oh gosh, way too
At
many.
least 12, at least 12, probably more than you're going to want to hear him.
That's
But
true.
anyway, face to face with Dr. Brewer, highly educational. And we have some options for packages for the conference where you could either just attend and just kind of absorb all the education, or you can get different kind of testing done and have an actual consult by Dr. Brewer, one of our providers. And a lot of our patients are not current patients, but prospective patients are kind of using this as kind of a weekend to just jumpstart their whole program, where they can kind of get a deep immersion and experience with Dr. Brewer, understand the kinds of things we talk about every week on the show, and then be able to look at their own lab results and scan results and be able to put it all together right at that weekend. And so we're really excited about it. It's the first one you've done since when? Before the pandemic, Ford?
Yeah, we had one. We were doing a new model where we were having a lot more people that we opened it up. Usually it was more of a pop-up, you have pop-up restaurants and other pop-up events. We were having a pop-up clinic. That was the most popular point. But we had a lot of demand for people to just come in and attend. And we had, gosh, 150, 200 people coming in. And it happened to be like April of 2020. So it was right,
timing.
right when the pandemic shutdown happened. So we got very frustrated. We got busy in a lot of other projects like the Alabama project. And so it's taken us a couple of years to get rolling again.
Yeah, so we're really excited about this. I hope you can see the phone number on there. It's kind of small at the bottom. But I mean, call the office, 859-721-1414. There's a bigger one. Thank you, Gilbert. And whoever answers the phone can kind of give you an explanation of the various packages that you can do, depending on what your goal is for the weekend.
So anything else about that before we head on?
Nope, I think we're good. Oh, I probably should tell you all, there is an early bird special right now that'll probably be available for the next couple of weeks. So try to jump on this to save yourself 30%.
Wow. Are you sure I agreed with that?
That was an executive decision that I made for you while you were on vacation in the Grand Canyon.
Oh, I meant to mention, my appearance is kind of funny today. I've got this, it looks like I've had a black eye for the past 2 or 3 weeks. I've got this problem with skin cancers. I've had about 40 of them. And I got them from my mom. She's had close to 200 of them. And there's a thing called an adjuvant for the geeks out there. Adjuvant is something that stimulates an immune response. So what happens in families that have problems with cancers, it's not usually that they have more of that cancer. It's that their immune system doesn't know how to recognize it, pick it up. All of us get cancers all the time, but most of us, when it's in a cellular state, very small, our immune system recognizes it and mounts defenses. For people that have, quote, the cancer gene, the breast cancer gene, those are all really genes where your immune system just doesn't recognize that cancer as well as most folks. So an adjuvant is something that you can put on that cancer and make it visible to your immune system. And so you use that in this, and I've looked like did you see Two-Face, Jimmy? What was his name in the Batman movie? Where his whole half of his face is just.
Is that what you feel like now?
Mm-hmm.
Yeah, Tommy Lee Jones. Yeah, I feel like Tommy Lee Jones.
You look fine to me. I can't really notice it. So.
Oh, you didn't see it. You didn't see it 5 days ago.
you do have a raspy voice today, so I don't know if
It was not a wise choice to do that and then go to the desert where I'm out in the sun and the heat all day long. But it is what it is. And yes, I'm in the Grand Canyon. We're very excited. We hoped we could broadcast from here. We actually thought about broadcasting from Bright Angel Trail. For those of you who know it, it's right in the canyon, but that's just not going to happen. Anyhow, why don't we get started with the main event? Fred, you're the main event. Speaking of which,
all right,
I'll see if I can get Jesus to join us.
I'll describe the journey. Jesus is probably tired of hearing about it. So anyway, just so you know, background, I was an athlete my whole life. I ran, exercised, lifted weights, very healthy, probably a little overstressed, overworked, kind of an adrenaline junkie, which has probably led to some of my heart issues, and ate generally well. Although I was a carboholic in my earlier days, I was always thin. And as an athlete, I kind of got the opposite problem of most people. I was always trying to gain weight. There was a day, and I had a lot of food allergies. There was a day where I ate a pound bag of potato chips every day. And back in my 30s. So I don't know if that set the stage for my problems 40 years later, but for the last 30 years, I've eaten quite well. And so all of this came as quite the surprise. So going back 2017, I'm exercising one day and my heart rate jumps to like 160, 170, like in 1 minute. And it's like, oh, this is weird. And so like a typical male patient, I thought, well, I'll just see how this goes. I'll keep exercising and I'll see how this goes for the next couple weeks. So it happens every day. And I like, okay, I guess it's time for me to go see a cardiologist who I'd never been to. And I was 67 at the time. I'm 72 now. So I go to a local cardiologist. I live in the desert. I live in Scottsdale, Arizona. He says to me, you are severely dehydrated. And I think that'll fix your problem. And I'm like, okay. And he says, you got to drink 4 liters a day at your size in the desert. So I start drinking 4 liters a day and just start monitoring things. And then I progress over the next, 7-8 months into a very irregular kind of heartbeat, and still jumping when I exercise very high. Okay.
So I hope you're okay with interruptions.
Oh yeah, for sure.
Speaking of your athleticism in the desert, I can't help but orient the viewers a little bit. You're still, you live in the desert.
Yep.
You get up, you drive your car over to a place that's like a hot yoga place.
Oh, you want me to talk about that? Make a plug for HotWorks?
And you go through a 90-degree weather in your car, in your air-conditioned car, over to a hot place to cycle, right?
Well, it's even more extreme, probably. Yeah, it's some days I go from 115 degrees outside, a little cooler inside my car. But
so I've asked this question before. I'm not sure that I ever understood it. Now, why don't you just cycle over there in the 115-degree weather?
Yeah, that extra 20 degrees I really like. Believe it or not, I mean, this is another health factor. I kind of don't sweat. And so Jesus.
Hey, how are you? Go on. I didn't mean to interrupt.
I can't. It's a great opportunity, since Jesus is interrupted, to introduce and announce the late Dr. Jesus Vega.
As usual. Meetings start at the 15 mark of the hour just because of me.
There you go. Now, Fred was just trying to explain why he gets up in the desert, drives in his air-conditioned car to a place where he can turn the heat up and cycle indoors.
Yeah, I would love an explanation for that.
Yeah, well, but believe it or not, yeah, just so everybody knows, Hotworks is the name of the place, not to plug them. They should pay us something, I guess. But I cycle. I do a HIIT routine now in 130 degrees. Which, if there's other people in the room, these are small rooms, but you can have up to 3 people. Sometimes it probably gets hotter than 130, and believe it or not, it takes me. So, like, why would I go from 115 to 130? First of all, it's not 115 year round. So, second of all, that extra 15, 20 degrees is about the only thing that makes me sweat. And even at 130 exercising it probably takes me 20, 22 minutes before I break a sweat. And so,
Wow.
You know, that is interesting. And in reality, I've got some interest in that heated exercise. You know, as I used to be a marathoner, and there were times when in the summer when you're running in hours in that kind of heat, it really changes your set point. I, like most people, have the opposite problem that you had about weight. I was always working to keep it down, but not when I was running in the heat. We'll have to have another different episode on that. Let's get back to what you do when you show up in the ER with chest pain.
yeah, we really haven't talked much about my lack of sweating problem, but that's for another day. So anyway, my heart is becoming more irregular. I'm starting to read. I'm 6'6", so I'm starting to read that tall people and basketball players, which I was, generally have a tendency toward atrial fibrillation.
Mm-hmm.
And so anyway, I'm starting to read about this, and I did not, since my traditional cardiologist, I thought, missed the boat already. And I didn't generally like to go to traditional doctors to begin with. I found not to mention names, but found a cardiologist traditionally trained who dropped out of the system and became all natural. Now, when I say all natural, it doesn't mean he never prescribes medication, because he does. But I mean, he just kind of dropped out of the system. And his big angle was the paleo diet, which I was probably doing very close to begin with while my situation was progressing. So anyway, I start visiting that practice. They put me on a bunch of supplements, and my atrial, and at the time I'm thinking my only problem is atrial fibrillation. I don't think I have any kind of arterial plaque issue at all. And during this period of time, I go get a Lifeline test, and they tell me I'm 100% cleared.
Mm.
So another misdiagnosis along the path. And so anyway,
you were nice and thin. What was your BMI? At 6'5", and what was it, like 20, 21?
Yeah. Always in that range.
And your blood pressure was okay, Fred?
No, blood pressure was a little high. It was generally, it would go up to, I mean, there were times when it was 140/90, but generally not any higher than that. And beta blockers, I just despised them. They made me feel awful. And so I was like, well, I can get this down naturally, so on and so forth. And it generally had never been a problem. I had actually here's another one. I'd been to a traditional doctor before, when I was in a very stressful time, my blood pressure was up. And being a lifestyle medicine guy from the beginning in the wellness business, just for yucks, I said to him, is there anything else I can do for my blood pressure other than medication? He said, nope.
Wow.
It's like, okay, well, you've just confirmed everything I've always despised about the system. And so anyway, I now start getting, do we pronounce it angina or angina here?
I prefer angina, but your preference is fine.
Well, you did train me not to say preventative, so I'll never say that again.
Well, I do get it irritated.
Yeah. So I will forever say preventive instead of preventative.
Mike Parkinson taught me that.
Yeah, so I don't want to go against your educational gurus. So I'll call it angina for this exercise. So anyway, now I start to develop pain, and I'm talking to my doctor. I'm getting this pain. He's looking at all kind of the blood tests, the markers he's looking at, and said, I just don't think, you have any other issues. I think it's some form of angina. And, the recommendations I'm going to give to you are going to be the same anyway. So just doing your diet, doing your exercise, la-di-da-di-da, and let's just monitor it. And my angina would always go away. It would generally come on when I was like at, I don't know, 140 or so. And remember, my heart rate was elevating very rapidly during this time because I obviously they actually diagnosed it as atrial flutter, not atrial fibrillation. Maybe it's worth talking about that, Ford, but you can decide. But anyway, so it would always go away. And so it was keep my heart rate down, which was hard to do because I kept exercising. But I would always back off when it got too intense. And it would go away immediately. So ironically, I'm at Whole Foods one day, and Mayo Clinic is literally 2 blocks away in Scottsdale, Arizona, if any of you know where that is. And it's raining, and I sprint to my car coming out of Whole Foods, and I get severe chest pain. And so I sit in my car waiting for it to go away like it always has, and it won't go away. So I thought, okay, I'm going to drive home, which is about 5 hours. Yeah, this is like one stupid after another, which is probably very typical for what people do. So I decided I'm going to drive home take me about 5 miles away. I happened to drive right by Mayo on my way home. And I thought, okay, I'm going to turn into the parking lot and sit in this parking lot just so I'm closer in the event I pass out or something. So instead of going into emergency, I park my car and I open up my door right so the security guard can see me. And I'm thinking, if I pass out and fall out, he'll at least know to come get me.
That was not a good day, was it?
Well, but
it got worse.
I think this is very common.
It's far more. That's what, and you're right. You pointed it out, and we haven't discussed it yet. So
looking back, you say this was really stupid. That was really stupid. That was really stupid. But it's like at the moment, it made all the sense in the world.
It sounds terrifying, and I have a couple of comments to that, if I may. This is what we called. This is the difference between what we call a stable angina and unstable angina.
Yeah.
So stable angina is you're having chest pain, but then you sit down, take a deep breath, and the pain goes away. So not a big issue apparently. But I can imagine your surprise when you try to sit down, calm down, and the pain just doesn't go away.
Yeah.
and
First step.
and just by the clinic, by how that looks like, it's impossible to differentiate between a heart attack and an unstable angina just by looking at the symptoms.
Yeah.
The symptoms are the same until you get to the ER, and then you get some testing and then help you figure out if this is a heart attack or no. So I think this is one of the key concepts that we wanted to bring out, because it's scary if the usual non-medical professional person will not identify the difference between a heart attack or an unstable angina, and it's scary. And the second part is how much of that decision of not going to the ER was financial. Maybe it wasn't on your case,
No,
but
zero.
but
No, it was zero. It was just pride.
but I bet a lot of people are having that financial
Yeah.
point on their mind on deciding to go to the ER, or just waiting on the parking lot for the pain to go away so they don't have to go bankrupt.
There's
So
this stupid something talking in your head that says you don't want to go in there and it's nothing.
Well, hey, did you wake up that morning thinking it'd be nice to spend the day in the ER?
Well, yeah, of course, everybody likes that idea, but Mayo is really nice. So if you're going to ER, it's one of the better places to go.
and I know some ER people that not even them want to go to the ER.
Right.
Not even to work.
Dr. Brewer is one of those, right?
What's that?
I become one of those at some moment. So yes, it's a really high stressful place as well for the providers. Too.
Yeah.
Oh yeah, it's a stressful place. I mean, I remember they had to. I remember them having, when I was at Charity Hospital in New Orleans, them having to shut the hospital down to bring in guys who part of the thing they would do to try to get out of prison or jail was stab themselves in the belly or something. So they'd have to take them to the ER so their buddies could come get them out. Great place to spring somebody from jail. And it was also a great place to come if you were on the other team trying to kill him. It was also a great place to come wipe him out. So it's like, and the doctors are in the middle of all that. So ER is not a great place to be.
I thought that just used to happen only in Mexico, but now I'm understanding that that's not the case.
Yeah, I'm not sure that Mexico was that much worse than Charity Hospital, New Orleans. We've got some good questions. JMK's had a couple of really good ones. The first one is, wait a minute, guys, it's 2023. Do the cardiologists still not believe the results or the conclusions of the ischemia trial? Great point. We bring it up all the time. We will discuss this a little bit later. But yeah, I mean, Mayo's a great name. And what do they want to do? They want to do a cabbage. What does the ischemia trial show? Bypass grafts, coronary artery bypass grafts. They do not prevent heart attacks and strokes. Where did that come from? That came from the Courage and Orbita trial. You remember in the beginning of the show, I mentioned the poster boy for passing a stress test and then dying of a heart attack, Tim Russert. Even his doctor who did the stress test said, yeah, I did a stress test on Mr. Russert. He went on the show to talk about what happened the day he died. And he said, I did it, but we just had a trial. It was called the Courage trial. It demonstrates that that stress tests don't predict heart attacks. The Orbita trial then came on later, and it compared people that had stents to people that didn't. There was no decrease in heart attacks for people that had stents. So that was the setting when people said, oh, well, maybe it's not stents then. Maybe stress tests don't predict heart attack. Maybe stents don't prevent them. It must be bypass. And yep, you go to a place like Mayo, who's supposed to be really good. And they're telling Fred to get a bypass. So we'll get to that a little bit deeper in a few minutes.
Yeah. Can you continue, Fred, with your
Yeah.
story?
So anyway,
You were in the parking lot,
so
waiting for the guard to see
I'm
you
sitting
when
in
you
the parking
passed
lot with
out.
with my door open, trying to make sure the security guard is looking at me. And he's like 30, 40 feet away.
I will have used a flashlight, probably.
Yeah. And anyway, I thought they could drag me in there if I passed out. So it continues on. So I finally get out and literally stagger in. I couldn't even walk upright, stagger into the emergency room. And just so you know, this is probably interesting too. I've been told everybody experiences this pain different. And mine was in my throat and in my traps and it was not in my chest. Okay. So I'd feel like I was choking and it would be, throat, traps, upper back. So anyway, I stagger in. They obviously think I'm in bad shape. They take me immediately back. They do an EKG. Now I'm probably, I don't know what, maybe 45 minutes to an hour into it. My pain does go away as I'm sitting there. So then doctor comes in, says, the description was, your EKG's all out of whack. And I'm like, okay.
Was that the clinical term?
That's very clinical. I probably wouldn't understand clinical anyway, so out of whack's good enough for me. So they then admit me, and they go down and do the angiogram, right? And then they come back to me and say, okay, here's your problem. Your three main arteries are 80 and 90% blocked, and you need to get quadruple bypass surgery. Okay, and any of you that have been to Mayo, a team comes upon you in your room. I mean, they bring the atrial fib guy, they bring the cabbage guy, they bring the resident, you're talking to like 5 doctors and you're in a nice room. My wife had shown up by this time because we're now a couple hours into it, and she's freaking out because we were only like 10 minutes away from Mayo. And
so you had your wife freaking out and your pastor there.
Not yet. No, the pastor didn't show up yet. No.
Oh, okay.
No, it wasn't like Fred's on his deathbed, pastor showed up, last rites. That was not it. He came later.
He got his lawyer first.
He came when I was okay.
His wife brought his lawyer.
That even made me more nervous. So, they're coming in. They got the A team. These guys are supposed to be the best of the best. And, I'm like, say what? So I'm 80 to 90% blocked. You're going to open up my chest. That's the only option. I'm just not having it. Anyway, that was like a Thursday night. I think the doctor showed up Friday morning. And the good news was they couldn't schedule surgery until the following Tuesday. So I had to sit there over the weekend and think about it. And, but at the time there was no choice. So I now have this embedded in my brain that this is my destiny. I'm now starting to call people that I know. My paleo doc, I'm calling him and he's saying, well, it might be the appropriate thing to do. It might not. And I can't really get a good answer out of anybody. And I'm now starting to talk to the people who really know, the nurses. Heather's shaking her head.
Yes.
That's another fact.
Yeah.
Yes, it is.
Yeah, I'm now starting to grill them, and I feel like the information I'm getting is much more objective. And they're like going, well, these grafts don't last forever, kind of putting a lot of doubt in this thing. literally Sunday, I'm now 4 days into the event, a resident shows up with a nurse and says, you can do stents. I'm like, say what? I said, no, nobody, in fact, they've told me the opposite. They said, sure, you can do stents. I'm like, okay, well, that sounds more interesting than opening up my chest. And so literally the following Tuesday, I had 4 stents put in. And I think you can show that. Do you have a graph of that?
I don't think I have your pictures, your exact pictures of those stands.
Oh, you don't? Okay.
But we have some academic purposes images of what a stent looked like.
And they did tell me supposedly. Now remember, I still have atrial fibrillation. Okay, and they are atrial flutter.
I do too. Well, I've got atrial fib.
Well, I had it at the time. I'm trying to say. So this is going on. So they have the AFib guy in there too, who's also telling me the good news about doing the quadruple bypass. He can do the AFib procedure at the ablation at the same time.
While he's in there.
So I get a 2-for-1.
Mm-hmm.
And I'm like thinking, okay, I mean, this sounds horrible, but I mean, maybe I can like solve a lot of problems here at one time, because now I'm going to go forward with the stents. I'm going to still have AFib, and it's like, okay, whatever. But anyway, the idea of opening up my chest just sounded deplorable, and I chose to do the stents. They put them in. I mean, I walked out of there a day later feeling great. And here's my question to you guys that I think people should know. Okay. What would you have offered the option to me at that point to do nothing?
On a very practical basis, I think we do that all day, every day now.
That's why I'm asking. That's why I'm asking.
We have people come to us and they say, I've been, my doc's saying we got to do a bypass, and I've been watching your show, and I don't think bypass is going to work. I don't want one. And here's what we say. It's the same thing about bypass and stent. I don't think those stents hurt you. The evidence, and I'm not going to tell you that it saved your life or it didn't. I do quote the evidence, and I've just quoted it 5 minutes ago on this show. It's your stents probably didn't prevent a heart attack. Now, there's a slightly different question. Will stents fix angina? And that's a little bit of a muddier picture in terms of the evidence. I tend to, when they did the Orbita trial, they didn't get much improvement on angina either. So does that evidence alone indicate that stents don't solve angina? No, I don't think it does. I think there's too much evidence out there where people are crystal clear that, I had it before. I got my stents. I don't have angina anymore.
It did solve that for me.
And you hear it's like you're really comfortable with that. So I'm very hesitant to say, no, that it won't solve that. Now there's we keep talking about how they don't work. That's not always the case. If you are in the middle, or if you're currently having a heart attack event, there's a clot there. It's not that your plaque, as we discussed early in the beginning of the show, it's not that your plaque is squeezing the blood supply off. People think that arteries are like copper plumbing in their house. Arteries are not like copper plumbing in their house. They're like these new garden hoses that expand when it starts to flow. So that's why this whole plumbing analogy doesn't really work. But as we said, it's not the plaque, it's the clot. And if you have a clot and they can go in and do a stent and take that clot out as a part of that stenting procedure, it can and will save your life. But the problem is only 10% of stents are done for that purpose. The other 90% are done to prevent a heart attack. And they just don't.
Heather, I'd like to ask you, I'll be the moderator here. I'd like to ask you the question. I mean, you were in the traditional system for a lot of years before you met Dr. Brewer.
Correct.
So was my experience typical with what you saw?
Yes, very much so. And especially when you said you had that team come to your bedside and you had 5 different doctors you're talking to and probably medical students as well. And that can be very overwhelming to those that are not in the medical field. So for you, you were in the medical field, you know, so you were familiar somewhat more than those that are not. So it can be very overwhelming, and it kind of becomes that Charlie Brown, like, rah, 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 because there's so much information coming at you.
Yeah.
Or sometimes I feel like patients just need to say, whoa, time out. This is a lot of information to digest. What are my options? Can we step back 10 steps and, you know, really try to advocate more for themselves? Because I feel sometimes, you know, once they make up their mind, this is what needs to be done. Like there's no option, you know, are there other options? But yes, me personally, when you ask that question, you know, should you have done nothing? I would have said no a year ago. But since working with the Dr. Brewer and the team, I have a different perspective on that now. So I would have said, yes, go home, you know, let's have you follow up with, provider or do your research, you know, get a little bit more information. So you're armed more to make informed consent in regards to next steps for your health.
Yeah. I mean, you said exactly what I expected you to say. So here's what I think is helpful to viewers and kind of the reason Jesus and I were talking about doing the show. I mean, that's sort of the moment of truth, right? My pastor did come like day 4. And I thought maybe he does know something I don't know. And, you know, so whatever. But my wife is stressing out, obviously, the whole time. My kids are whatever. And, but I think we need to give people a framework when they're at that moment in the emergency, and now they've gotten a diagnosis, they have their data, it's either a heart attack or it's not. You know, what are my fundamental assumptions I'm operating on? Because the way I will tell you, 99% of the people I hang out with who are all baby boomers at some risk of some chronic disease, and myself, the theory is you start to get that level, I mean, 50, 60%, that my assumption is I got to get that open some way, somehow.
Mm-hmm.
And it's going to have to be through one of 2 options, stents or a bypass. And so to me, we need to educate people. What's my foundational principles and assumptions I'm operating from when I start hearing the doctor tell me what I have to do?
So I've had 2 people come on board and tell their story. One was Gene Lovell. The other was Lois Pride, both of whom were in that very same situation. And they bit the bullet. They said, okay, I'm going to get the bypass. You know, Lois was an interesting, she had an interesting story. She had familial hypercholesterolemia. She knew it. And she was just used to, for over a decade, she had been, you know, she'd see a new doctor. He or she would panic, try to beat down that cholesterol. And she would just say no. She came to our event in Louisville. She got tuned up. She was doing fine. She happened to go to a doctor with her daughter. And this event that you described, the whole team comes flying in. The way you put it, Heather, was so funny. And she's laying there. She's been there before. She's totally comfortable saying no, but she looks over at her daughter, and her daughter is just devastated and panicked. And I get people that are in this decision process all the time. And like I said early on, I don't, it's proven getting a stent is just not that dangerous. That's not what's going, getting the process of getting it put in is not going to hurt you so bad. The thing that hurts with a stent is the mistaken assumption that this was plumbing and my plumbing's fixed, so I don't have to go back and fix my metabolic health. Somebody asked the question, well, how do I prevent? I just had a heart attack. How do I prevent my next one? Metabolic health. We've had multiple discussions about it. Get your OGTT, get an IR, find out if you can, what your metabolic health is like.
But let's take it a step back. Okay. Not so much how it's going to help me down the road, but so are you guys saying, and I think I know what you're going to say, because I'm grilling Jesus on this, and I wasn't even happy that he really definitively told me the answer. Let's say hypothetically, I mean, in actuality, I was 80 to 90% blocked. And let's say it was even worse. Let's say it was 99% blocked or 100% blocked. Should we tell our viewers that at that moment, you should be thinking, I have the option of doing nothing?
Well, improving your metabolic health is not nothing. I mean, you got to get an.
I'm sorry. Yeah, not what I'm saying. Nothing are the recommendations they're going to make for you, stents or bypass. Yeah. So, are we saying that even at that kind of a situation, there is a consideration that you would not get stents or bypass?
We say it all the time.
Okay,
we say it on the show.
I want to get that on record.
I'll say something before we move on the topic. One thing that is important is what you just described. I'm guessing you did not have a heart attack.
Correct. I did not have a heart attack.
You did not. You will have been rushed to the cath lab and put a stent. Like you need to decide ASAP, sign in this form, and you're going in. If you
I did not have a heart attack.
So in which case, we would say that was a good thing.
Right.
Yeah, and if you're having a heart attack, you need a stent.
Get the stent.
Bottom line, yes. Now, I think there's a difference between having an 80%, 90%, or a 99, 100% blockage. Because, as in your case, if it was like 80 to 90%, it means that blockage was being created for years.
Right.
And there's still some blood flow going over there. And very likely you even developed something that we call collateral circulation. Like, how do you describe, Dr. Brewer, that? You mentioned that is like...
detour.
Yeah.
Detour. I forgot that word every time. So you're having some blood flow going through some other place to feed that part of your heart. And 2 weeks ago, I grilled back Fred on, hey, you're asking me all these questions, just watch the show. And 2 weeks ago, we presented that information. And for people who are 80 to 90% blocked, medications and improving metabolic health is an option in those scenarios because there is still blood flow. There is helping that heart. The issue comes when you're starting to have chest pain. And that chest pain is just not comfortable. It doesn't allow you to improve your life, your daily life. So the evidence is still contradictory in regards to the chest pain. Some people see benefits, some people don't see benefits in regards to the chest pain. So that's when you put on a balance on you make the decision of, okay, I'm gonna go with medications and lifestyle, or I'm getting the stent just to see if my chest pain goes away. When you are 99% to 100% blocked, again, there is collateral blood flow over there. That's not a heart attack. That's not something that happened one moment to another. It happened in the course of at least months.
Jesus, can I stop you there?
Sure.
are we making the assumption? Let's go to the 100% blocked, because I think that gives us a baseline, right? Worst case scenario. If you're not having a heart attack and you're 100% blocked, you assume you got
It's got to be
decent
collateral.
collateral blood flow.
That's the more probable situation. Of course, you do an angiogram and you can prove that. Yes, you can test it. You can identify if that's your case or not.
Okay.
If that's not your case, if you don't have collateral, that blockage is going to look more like a heart attack.
And
you can see that.
For the viewers who have more interest in this specific question, we did cover that. Jesus and I talked about that. What was it, 2 weeks ago?
2 weeks ago. Now, I'm going to tell you something about the stance on the scenario of having 100% blockage. It's different to go with a stent to some place where there's still blood flow. Like you can still put the stent in and open it up. It works. But when you have 100% blockage and a lot of that plaque is calcified, it's hard.
To get the stent.
It's difficult to go in.
Yeah.
And they have to play around and see how they're going to do that. And the possibility of that stent fails is higher.
Okay.
And when a stent fails, you're very likely to require another one or another procedure or go to the bypass instead. And so you have to know that even in that scenario, the stent might not work, and you will be in the position that, I already had a stent in and they told me that it was displaced and didn't work. I need to go in there again.
Or that they can't even put the stent in because they keep it.
Yeah. And then you have the decision of, okay, I'm going to get a bypass then. But how are you feeling at that moment? Mm-hmm. Are medications relieving your pain? Because I'm guessing on the ER, they gave you some medications for the pain. Nice. So I'm guessing that had something to do with your pain going away. Correct me if I'm wrong.
I can't remember actually.
And metabolic health lifestyle is something that you're going to have to do either way. So you can do that with your chest scar of your bypass, or you can do it without it. I would love to give you a definitive answer of saying, no, you don't need to do it. Yes, you need to do it. But every situation is different. You now see there are a lot of things to consider in each one of those. If I was you at that moment with an 80%, 90% blockage, I'll probably will get an stent as well if the pain was just too much. I have never had an angina-like chest pain. So I'm just seeing patients that have that, and it looks like it hurts. So if I have some chance that the stent is going to relieve that pain, I'll probably go ahead and get it. I'll definitely not a bypass on the situation that you just had.
A couple of points from my side. I might at some point, if I had long-standing angina, I might try that as well. Even given what I said before, it's about what evidence we have is not that clear that it actually helps. But it's not conclusive that it doesn't help with angina. Now, where I was going a few minutes ago is like I said, I'd think twice before I had a stent. And that's the situation that I would think about doing it. I'd think 17 times before I had a bypass. It's brutal surgery. You know, they open your.
Oh, I've heard.
And I've got Lois that I mentioned a few minutes ago told her story. She almost died. She had some blood. It's similar to thalassemia for the clinical guys here. It's a difference in the way her the genetics for her hemoglobin, that when she ended up having a transfusion, and then she started losing a lot of blood. So I was on the phone with her family a good bit during that episode. Gene shared he had challenges with that bypass. I've got other patients who it really impeded their ability to exercise afterwards because of the malunion. After they tried to wire the chest back together, it just hurt for years every time they did.
Heather will like to hear the nurse came in after I made the decision and winked at me and said, "You made the right choice."
Love it. I love it.
And I was like, okay, from now on, I know who to ask.
Yes. Yes.
Well, Heather, speaking of all this, I got the question to ask you. So when you agreed to go from being a nurse to a nurse practitioner, that's sort of like a demotion, right?
Yes, it can be. Yes.
I feel the same when somebody tells me Mr. Vega.
But
Okay.
no, right.
It was only 12 years of studying, but that's okay.
That's okay.
I've always been very, very clear that my role in the organization is that I'm the chief nurse and health coach assistant,
Love it.
because those are the guys that, I mean, it's like metabolic health. I mean, people start getting into, well, should I do vegan? Should I do paleo? Should I do this? And it's like, I start to feel like we used to have a dog that was really dumb, and the dog would do something really stupid, and you'd try to correct him, and the dog's just looking at you, and you're thinking, that's sort of the way I am when we get into that level of health coaching. I'm not the guy. I can tell you some science, but the people that really do the work are the problem solving, are on lifestyle. It's the nurses and the health coaches.
That's why I married one.
What's that?
That's why I married one.
Well, yeah.
That's why we value the Heathers in our organization so much.
I appreciate that. I value you guys too, for sure.
Speaking of all this, I'm going to have to go, Heather. I've been yakking way too much. I'm going to give you some more airtime here. I don't, now we got Jesus on, so you're going to have to scratch and claw to jump in there, but at least you'll have a little bit less with me out on Bright Angel Trail.
If you let me, I monopolize the situation. So.
Oh, I know. You got to keep after him.
Yes. Okay. Noted.
Bye-bye.
Bye-bye.
So Dr. Bird just came in, answered the tough questions, and then leave. So I appreciate that.
Yes.
Well,
Fred, do you want to?
I have more Jesus. So.
Oh God.
Oh,
Okay.
Although
Heather, you're on your own now.
Oh no.
Although I really do. I mean, I just think that kind of if we can help patients. I mean, I think everybody's biggest fear is I'm going to land in the emergency room. They're going to find something. I'm going to be in a high stress environment. I got to make a decision. It's the worst place to make a big decision, and I won't have time. And I don't know how to challenge, the top cardiovascular surgeon at Mayo. And you may be
very intimidating. Absolutely.
Yeah, you may be taken down a path that isn't the best path to take. So to me, I hope that's helpful to viewers, because I think we all have to prepare for that moment that could happen if you're at some heart risk, because that is where you don't have time to think. I don't want to beat a dead horse here. That's probably the wrong analogy to use. Keep talking.
The wrong horse on the parking lot.
But I think that's where people I hear it on the phone all day long. This happened. I went to emergency. This is what they told me. What do you think? And I mean, that's almost most of our calls have had some experience like that.
Yeah, and just also as a patient, you need to be aware that we're gonna ask a lot of questions. I mean, that's what that question is worth the visit with a physician or a nurse practitioner, because there's just so many variables involved until you get a final recommendation, and even that recommendation is gonna be like, I'm gonna show you the risk for each decision.
Yes.
Well, yeah, and I think we need to equip our viewers with questions.
And it's an emotional time. Emotions are very high. You've got family members involved that are, scared and upset, and, we're concerned about their loved one and the safety and, living through the night. And sometimes, the medical team can approach it as this is a life or death decision. And I don't necessarily agree with that in certain circumstances that we've already discussed. But yeah, helping our patients know what questions to ask. The biggest thing is, what are my options?
Let me ask you, here's before we get to the rest of the story, a friend of mine just had a heart attack. and he's 4 years older than me. So they said he had one plugged up artery, which he had no idea, soft plaque versus calcified. And they put in a stent and they said, go home. He really had almost no information at all.
Wow.
And then 2 days later, extremely severe heart pain, chest pain, and goes back in and they say everything's fine. So what do you think that was?
It can be a lot of things, but one thing that we see a lot that can get confused with a heart attack is something that we call Prince metal angina, which is a spasm of the vessel. So whenever you're having reduced blood flow, that's the cause of the pain, basically. So that I don't think we ever I think we said that a few shows back. But the cause of that chest pain, of that angina, is reduced blood flow. That's a fact. So sometimes the vessel can go just too thin or just squeeze, and that contraction of the muscle between the layers of the vessel can cause pain, and that can happen after a stent.
Okay. Yeah, because now he was totally confused. He said, I 100% thought I was going to die. I just, now it's the second time in 3 days, and whatever happened the first time didn't take me out, but this one will. And then they tell him, go home, you're fine.
And the other thing that you want to consider is, even with a stent placed in, the next 6 months to a year are the highest risk for a second heart attack. Okay. So after you have a heart attack, you are on the line. You are on the red alert that it might happen on the following 6 months to a year.
Okay. No matter what intervention you've done.
No matter what intervention.
Even with bypass?
Even with bypass, it probably is going to be less. It's going to be less risky. But think about what having a heart attack means. Having a heart attack means that for a lot of years, you developed soft plaque, and it just it ruptured in some place on your heart. So it means that you will have more soft plaque elsewhere. And it's impossible. I haven't seen, maybe they can do a quadruple bypass and help with a lot of those arteries. But you're going to have always the risk of another place where there's soft plaque to rupture again if you don't change your lifestyle.
Right.
Okay.
So that's the big issue. And that's the conundrum that we're seeing here. You can see a bypass or a stent like something that's going to get you some extra time, keep you alive. But if you don't change your ways,
correct,
history is going to repeat again.
Yep.
And sooner rather than later, probably.
Yeah.
So we can continue with your journey. What happened the next year after you got your stents?
Okay. My angina came back. Not as bad. And they had always warned me that stents could last 6 months, and you get occlusions again and so on and so forth. And so anyway, my angina came back probably, I don't know, within a year. Not as severe, but now I'm obviously, I should have had bypass, blah, blah, blah. And I changed doctors, and I know we're sort of agnostic about diet, even though we believe in certain principles. But I had been on a high meat paleo diet during this whole time, even before my event, and things got worse. So I went to a new guy, and he said, why don't you try Mediterranean? And I'm going, okay. He said, it's the most research, it's the most this, it's the most that. Why don't you give it a try? And he said, and he was the first guy that then introduced me to the idea of building collateral blood flow. And he said, I want you to exercise in a particular way. And I was kind of already doing it, but he was recommending HIIT. And he said, I want you to be thinking now that you can build collateral blood flow even if these stents plug up again. And you'll be fine. And I go, okay, I'll do that. So I did both those interventions and my angina went away. And that is now probably, let's see, that probably 2020. So we're probably 2-3 years ago and still have no angina. I still had atrial flutter problems off and on. And
Even with the ablation, right?
yeah, I'll give you the story on that. Just so people know an interesting fact. I read about root canals causing AFib and heart disease. And I got my root canals pulled out and my AFib went away for 10 months.
Wow.
The next day.
Wow.
That's interesting.
That is.
I got a false tooth here now. So I didn't put metal back in. So I got a piece of plastic.
And root canal, I had one like a couple of years ago, and root canals are not fun.
No, they're not. I've had one.
Not only are they not fun, well, I don't know if anybody's seen what a root canal looks like when they pull it out. It is black. Your tooth is black. It looks like death.
It's actually that they're keeping your dead tooth body right there.
Yeah,
just to keep a piece of teeth.
And my understanding is, hopefully, there's people out there that know more about this than me, but the layperson description of this, it leaks into your system, and there's even different teeth that are different oriented toward leaking into different organs. So mine that I had, I went to a biological dentist, and she said, yeah, where your root canals are the ones that leak into heart. And so anyway, my AFib went away literally the next day. It was crazy.
Wow.
Awesome.
And that lasted for 10 months. And this may be too much information. It came back when I took Viagra. And then I looked, does Viagra agitate AFib? And like everybody told me, no, because it opens your blood vessels. But for me, it got me back into it and it never went away. And so now I was like really angry at myself for doing that because I was on such a good path. And then I really did a lot of study about ablations, which I had done from the very beginning. And I tried to fix my A-flutter naturally. And I went and so I actually went in, this may be a controversial topic too. I went in because a friend of mine had a stroke, and I said, I'd rather be dead than have a stroke, based on what happened to my friend. I'd rather have a heart attack and just die. I know where I'm going, so that's fine. So, the stroke looked horrific. So I went to an electrophysiologist, like top guy in town, Doogie Howser kind of guy, medical degree at 16, that kind of a deal. And I went in to get the Watchman device. I had learned to live with my A-flutter. It wasn't that disruptive, even though it was constant. I could exercise with it. I wasn't having angina. And I thought, I can live with this. I just want to get rid of the stroke risk, and I don't want to take blood thinners. And I had been taking a natural blood thinner of a combination of nattokinase and serrapeptase. And I obviously didn't have a stroke, so far so good. And, but I thought I was flirting with disaster. So I thought I wanted to get the Watchman device. The guy told me he was in the clinical trial. He was one of the docs in the clinical trial. And he said, they leak. And he said, I don't recommend them. And I'm like, okay. And I had heard all kinds of other people rave about them. And even some of the others that are by different brand names. So, and he said, just so you know, an ablation for atrial flutter is very simple and very effective. And so anyway, I decided to get an ablation. That was probably 14, 15 months ago.
That's your second one then?
No,
Second ablation?
first.
But I thought you had one with your stents, so that wasn't the
No,
case.
they were only going to do that if I had bypass.
Open heart. Yeah.
Okay. So okay, I understand now.
Yeah, so it was a 2-for-1 on the bypass and ablation. They still wanted to do the ablation on my stents, but I was like, nah, I can live with this. So anyway, I'm now 13, 14 months out, I think. And I have had in the last 4 months, like 24-hour episodes. So I'm a little fearful. It's kind of unraveling, but and I know ablations don't last forever. It's very common for people to do multiple. But anyway, that's kind of this current state of the union of where I'm at.
And just so you're aware, Viagra doesn't only has effects on the vessel; it does have effects on the rhythm system of the heart as well. So it's been documented that Viagra can cause arrhythmias. It's not common,
Nope.
but it can happen, just like in your case.
Yeah, well, I never took it again. So
Good choice.
Yeah.
Just like the nurse did. Like, can you see me?
Give me the wink.
Doing you the wink.
Give me the wink. Yeah. Okay. So anyway, I can probably move now into meeting Dr. Brewer, which I am a new patient of Dr. Brewer, so I can't spout out results yet. But I will say this. I mean, I really felt like I was at top, who call themselves kind of functional medicine doctors, integrative, traditionally trained, highly trained, but just kind of went to the other side of a more natural approach. And even those guys never had me do the testing and the biomarkers that Dr. Brewer has. And I am sold that, I've kind of been flying blind, and I kind of tell people now when I promote what Dr. Brewer does, I mean, it's like playing a sport and you don't know how to keep score. And if you're not looking at these, the fractionation of the lipids, if you're not doing the insulin sensitivity and you're not looking at the right biomarkers, you're flying blind. And that's what I really consider the big difference maker of what Dr. Brewer does. The deep science, the new science that most cardiologists are 30 years behind. And, he probably has a unique twist. It's not just new science. I think he's very insightful about certain things. And it's like, I'm very hopeful that now tracking the right stuff that, even though my lifestyle has been good, I've made moderate changes, but I'm doing good right now. And I feel confident I'm going to be tracking the things that are more meaningful.
And just before we wrap it up with the stents discussion, because we're going to the lifestyle and how to track your metabolic health. If you see here on the slide at the bottom, this is a CT scan after the stents in 2022. 25 to 40% stenosis on the distal right coronary artery, 35% stenosis on the circumflex. So it went from 80 to 90% to 25, 40%. So there's still some plaque in there, even with the stent. And if you might have calcified plaque, that's stable, that's probably not going to rupture. But if you're not doing any changes, you are going to have some soft plaque that can rupture and cause a heart attack and create a clot even on the place where the stent is placed in.
Right.
We have seen plenty of stents being built up with plaque and being blocked again where a stent was placed. And I saw this comment. I don't usually do this. Dr. Brewer does that, squeezing comments before time, and even not YouTube members' comments, which I'm okay with that. I'm also encouraging everybody to become a YouTube member. But this comment is really good on this aspect. So this is from Your Dead Meat 69. So I'm guessing a horror film fan from the Friday the 13th, like I am. Have you seen that?
Me too. Yeah.
You are dead meat. real dead meat. I really like that.
I have no
So,
idea what you're talking about.
horror films have
Movies.
have their charm, and they become really popular in October and November. So uh, anyway, your dad meat says angina is terrifying. I suffered 3 months one after passing my stress test. No surprise. For me, the bypass was the repair. Two meals a day keto was the cure. 15 years still at it. So that's another example of what had happened. First, you get a stress test, you passed it with flying colors, and you think you're fine. Then you have a heart attack. Then you have a stent or a bypass. But you need to understand this. This might be a one-time repair option to give you some more time. But if you don't change the way you're eating, the way you're moving, the way you're managing stress, the way you're sleeping, all those factors involved on cardiovascular inflammation, you're gonna get another one. So I think that's the main message that we want to bring out there as well. So these are your labs, and this can become fairly technical. I don't think we're gonna have enough time to explain all of those individually. I'm gonna just highlight a couple of those. The first three that we see, MACR, CRP, LP plateau, are basically inflammation markers. That's the thing that we use to track. We're missing one, which is myeloperoxidase, MPO. And those can help you identify if your arteries are on fire or not. So those values are basically normal for Fred. The OGTT, the oral glucose tolerance test. So here you can see that those are basically normal values, optimal values. Fasting 97 glucose, 1 hour 126, 2 hours 63. So if you just do the oral glucose tolerance test, you might think, okay, it looks like everything is okay. No diagnosis for diabetes, no diagnosis for pre-diabetes either. But if you see the insulin response, fasting is 5.7, which is almost optimal. We would like it to see that less than 5. 1 hour, this is where this becomes tricky. It goes to 144. So this is after drinking 75 grams of sugar. And 2 hours after that, it goes way down, 8.5. So this is what we call the first phase response. It spikes. This should not go higher than 50. And it went to 144. So this is one way to identify insulin resistance. And insulin resistance has become, along with oxidative stress, they go hand by hand as the main causes of cardiovascular inflammation. So I will not be surprised that this is the reason behind all that plaque that you have developed over the years. Triglyceride over HDL ratio looks really good. LDL is high, so that's something that people will say, hey, are you sure it's the insulin response? It might be the LDL. And the reality is that the evidence, it's pointing fingers on to say LDL, it might be more like a biomarker, something that can lead you to think that you are having cardiovascular inflammation issues, but it's not as good, as specific as other things. And if you're familiar with David Feldman and lean mass hyperresponders, there's research right now going on trying to study people who have really high levels of LDL. They're lean mass, so they're not fat, they're not obese, they're not overweight, and it looks like they don't have cardiovascular plaque. So they're on trial right now, and I think that's gonna get published probably at the beginning of next year. We're gonna cover that because that's gonna be really really good research to identify. HDL large, that's how many HDL particles are big enough to be preventive. Small HDL particles do correlate with cardiovascular disease. So that's, and the pattern B is also the form of the LDL. The smaller the LDL, the worse the pattern. So those are two things also that will need to be improved. ApoB, LP little a, A1C, those are not that high. LP little a is higher than we would like to see. People who don't have the genetic modification of LP little a usually will have less than 10. But even as in Fred's case, where that's it is 117, we're not too worried about it unless it goes over 300 or 450. And just like LDL, LP little a is a genetic variation of LDL, and it helps us more like a biomarker more than something that we're gonna put the blame on for heart disease. I warned you, if you let me talk, I will monopolize the conversation. Any thoughts on this conversation?
No, I agree. I think that metabolic health, that's what I've learned so much about, and all these different labs that Dr. Brewer looks at. You coming from a family practice, this is not the standard what we ordered with a physical. So in the beginning, it was very shocking for me as a nurse and a nurse practitioner to feel so bad that I missed so much pre-diabetes, diabetes, or insulin resistance potentially. So, but yeah, for sure, that 1 hour insulin response is definitely an indicator of that insulin resistance that Fred has going on. And I know he's probably worn his CGM, his continuous glucose monitor, to see what foods might spike his sugars and how he responds, so he can learn more and kind of eat to the glucometer, so to speak. So yeah, those are my thoughts.
What about your experience, Fred?
I guess I mean, I don't know. It's just kind of, the insulin sensitivity obviously looks to be, I mean, you're kind of saying that appears to be the culprit, right?
Yeah. Well, that's what we have found and I can tell you, I didn't know this. I graduated from med school. I graduated for my specialty, and it was until I started working with Dr. Brewer that I found all this research, and I was like, why I didn't get taught this on school?
Right.
So yeah.
Yeah, it's, the complicating thing for me really is diet. Because, and I do have a theory now that I'm into it this long and my own problems, that it is kind of a personalized thing, because I was very low carb for many years, and I wouldn't doubt my numbers there were worse. Okay.
Mm-hmm.
And, and, I was eating a lot of red meat, and I was at the paleo thing, and it was clean meat. I wasn't just eating trash. And I was getting worse and worse from a standpoint of, well, I don't know if my plaque, I have no idea when I got worse with my plaque, right? Because I never measured it until it was 80, 90%. So I don't know, like 5 years ago, what was it? I have no idea. But my pain clearly got worse when I was low carb.
Mm-hmm.
When I went Mediterranean, my pain went away. And I really didn't do hardly anything different. That was probably the only thing I changed. Maybe the supplements I was taking was starting to have an effect after a couple of years or something. I don't know. But it really wasn't. So I'm now kind of a little bit, and just so you know, I have done continuous glucose monitors for periods of time, and I really don't spike with anything. I mean, I can't remember if I did it with an ice cream cone or something like that, but I know it was kind of unremarkable.
Okay.
It wasn't very informative. So I'm kind of sitting here going, what's going to be the best thing to get on top of that? Because Mediterranean, as you know, is more carbs, and so I'm sort of, I think what I need to do is to do something definitive here from an intervention. And I mean, let me ask you this. Is there anything else that's going to change that insulin response other than diet?
Before going answering for that, the part of the low carb diet, how do you define low carb diet as in your case? What was low
There was
carb
a day
diet
that
for you?
I was doing under 30, 40 grams a day.
Mm-hmm. And how much of the other stuff you were doing? Like, what can you give us like a hint of what you used to eat?
I mean, just a lot of meat. I even went carnivore for a period. A lot of meat, a lot of white, lot of red meat. Chicken. Never ate salmon, that kind of thing. Very little fish. Vegetables were my carb. Um, I mean, that was basically my diet.
Mm-hmm. Not so many vegetables.
I was much heavier on the fat.
Mm-hmm. Okay. And did the pain came after you eat?
No, had no correlation to when I ate.
Just
Oh, okay.
exercise. Was it just exercise
Just exercise.
or getting your heart rate up? Like when
Yeah.
you were running in the parking lot from the rain.
yeah, that was the big one.
Yeah. So I mean, it's hard to make a decision. My just immediate guess, without all the information, is have you seen how Gatorade and those sport drinks have become very popular? They have tons of sugar on them.
Oh, yeah. No, I've always been very low sugar.
Yeah. So I'm not saying this is your case. This is something that I have seen on some people. Um, Sugar, it has become a part of a source of energy in some and for some stuff, and those energy drinks might be helpful for athletes that spend a lot of energy and they need to repair and use that glucose really quick. So I'm guessing if the chest pain came only when you were having when you were exercising, that could be in stressing your heart to the point of decreasing the blood flow for the plaque that you already have developed. And being on low carb might have put you in a place where you have some low levels of glucose. So I'm guessing that will have something to do. I'm not saying that's the case. That's a just quick guess. You will need to talk to Dr. Brewer on the next visit and see all the other factors and came up to a decision with that. I think the bottom line is paleo, keto, Mediterranean, low carb. It depends on the person as well. And as you mentioned, it needs to be kind of personalized in order to see which one works for you.
I will
So,
say this, and I'm not saying this is for everybody because I don't believe anything's for everybody
No.
anymore. When I got rid of red meat, my pain went away.
mhm,
Mm-hmm.
yeah, it's really really interesting.
Yeah.
And to answer the other question is, um, it's only diet. What I can do for that? No, it's exercise, of course. We advocate for doing some aerobics, doing some. I'm when I say aerobic, I mean aerobic exercise. Just walking can help. Doing some resistance training, getting your muscles working, especially on your legs,
I do all that.
and some high intensity interval training.
Yeah.
All of those things help.
Yeah, I do all those
to
things.
improve.
Yeah.
And it's just keeping in check on keeping an eye on it, being monitoring that, because as Dr. Brewer says, there are three key factors that are involved with all of this. One is genetics, and it's just too much that you can do about that. The other one is aging, and you might be able to do a little bit more stuff on that, but we haven't been able to solve aging in either. And it's pretty correlated to genetics, so that's two. And the other one is body fat. So the less body fat, the more muscle that you have, especially visceral body fat. You have people that are lean, but they have a lot of visceral body fat. That's what we called thin fat people. Thin on the outside, fat on the inside. So those are three things that are important. So body fat is pretty much related to insulin resistance as well. It's body fat is a tissue that produces hormones and mess up with all the system. Heather, do you have any other thoughts on that one? I haven't. I don't think I ever heard somebody saying, "Oh, low carb diet caused me angina." But
Yeah,
I'm pretty sure I'm gonna do my research on it as well.
Yeah, and it's very individualized. Like we've talked about, diets, and sometimes you have to do trial and error. Not Mediterranean, it works well for you, Fred, but for other patients, they may have to go through keto or low carb or plant based. I mean, no one diet fits everybody's needs, so it is definitely can be trial and error at times. And I know you added HIT, I think, before your stents, or was it after? I can't remember for sure. So I would be curious to see what your OGTT would have been pre-HIT, adding HIT versus.
Yeah. And I don't know because obviously I didn't do it. So
because that HIT can definitely help increase.
Sounds good. So anything we want to add to your story, Fred?
I think I'm done boring everybody.
Did you get the message that you want to get out?
What?
Did you send the message that you wanted to send?
I think we've sent that. Yeah.
Okay. So I'm gonna.
Yeah, I really hope people are just prepared, kind of like if they have an event, you're sitting in the emergency room, how you need to be thinking and how you make your decisions. That's what that's what I want to do. I mean, I want to be prepared if I go again.
And that may be something that the team, the clinical team, we can maybe come together, put our heads together and come up with some suggestions on that. Because I agree. I think that would be very helpful.
Little handbook for people.
Yes.
For the atrial fib, they always talk about the pill in the pocket.
Mm-hmm.
Mm-hmm.
To take you out of AFib that you carry around with you all the time.
Mm-hmm.
I mean, to me, people who are at heart risk should kind of have, it's not a pill, but a plan.
Mm-hmm.
Plan in their pocket. What are you going to do?
Exactly right. And if you're watching the show and you are not in this position yet, but you're worried that you might be on this position, you came to the right channel, because we talked about that all the time. What can we do to prevent you going into the ER and getting suggested to get a stent or a bypass? Worse, having a heart attack and dying of it, and even worse, like just Fred said, having a stroke and end up on your bed on a wheelchair for the rest of your life. So that's kind of stuff that we want to avoid happening. And before we go to the question, if you allow me, I'll try to show these results from this. This is a key landmark study that we quote all the time in regards to preventing heart attacks. And I will try to do this in less than a minute if I can. So you know how we always say stress tests don't prevent heart attacks. You can pass a stress test and still have a heart attack. For that, instead of that, we recommend a test that is called the CIMT, Carotid Intima Media Thickness Test, which is an ultrasound to your neck. And this study, the Cafete Caves study, is the one that has shown how ultrasound, especially CIMT, does help preventing heart attacks. They studied about 13,000 people with no symptoms and followed them for 10 years. They measured their plaque on their neck and on their femoral artery as well. 2,000 subjects, around 2,000 subjects had plaque. And this is the interesting part. 772 events, meaning heart attacks, strokes, and even death, happened on those people who had some plaque, especially plaque that was creating more blockage. And the overall result was that 98.6% of cardiovascular events happened in people with plaque on their neck or on their femoral artery. So that's why the CIMT works. If a lot of people say, how do I know CIMT works if they're just measuring that on my neck and not on my heart? Well, this is the study. If you have plaque on your neck, on your femoral artery, on your carotid artery, you're very likely to have plaque on your heart, and you're very likely to have a heart attack, especially if that is soft plaque, not calcified stable plaque.
Hey, Susan, let me make a plug for the conference, okay? Because
sure, I have a slide for that.
Well, I know we talked about it before you came, but we can talk about it again. That's what happens when you come late, Jesus.
No, I was watching the show. I just
Okay.
didn't want this to happen, but I didn't know that Dr. Brewer was planning on me having like a backup and not leave you two guys alone for the first time.
Yeah, we needed you here.
Well,
We're going to be doing CIMTs at the conference, and that's part of the package, unless you just want to attend the workshops alone and get no testing. CIMTs are not readily available if you want to get it. And I mean, we hear this from patients all the time calling in that think they already got it, but the one that they got does not distinguish between soft and hard plaque.
Mm-hmm.
So if you think you've had one of these, you probably haven't. And the easiest way to get it is at this event. For example, I have to drive to LA from Scottsdale, Arizona to get a CIMT. They're not commonly offered around the country. And so there's real convenience of getting all that testing done at the event, which is a big benefit of it.
Absolutely.
Definitely. And what Fred says is really true. We see a lot of patients that say, "Oh, I already had an ultrasound on my neck," and they report only blood flow. And blood flow is not enough for us to really identify this. If they're not saying us that you have plaque, and especially if they're not saying us if this is soft plaque, which is dangerous, or hard plaque, it's just not useful. So save the date, Friday, December the 1st and Saturday 2nd on the St. Petersburg Marriott Clearwater on Florida. So we are getting ready. We have a lot of people asking for the event, so don't miss out. Also, you can go to our website, prevmedhealth.com, book an appointment, and also you will find more information about the event right there as well. If you want to get the early bird discount, you can go to the website, or better, call 859-721-1414. And that's my advertisement, boys. We might have some we might be able to address some questions. We're kind of over the time already. I just want to be able to address one or two questions, if that's okay. Gilbert, can you give us the intro to Q&A? So Dr. Brewer already went ahead and answered a couple of those. I want to give the shout out to the YouTube members, just like Peggy and Keith Lawson. Thank you so much for joining, and they're giving some nice words to Heather. Gilbert is showing right there how to join. Just click on the join button. It's a couple of bucks a month. It's not so much about the money. It's more about me being able to identify and prioritize some of the questions, because we always get a lot of questions, are not able to answer all of those. Any relation HRB plays? I'm not familiar with that term. Do you know what HRB is?
Probably heart rate variability.
Probably. I haven't seen that so much. So I don't know. I'm not sure what this was referring to. I think this question was brought up at the beginning of the show. Do you have any idea, Heather, Fred?
Yeah, I would say the heart rate variability. So I don't know if maybe they were, the Lawsons were asking that in relation to Fred's story, as far as, he noticed the angina pain when he was exercising, the elevated heart rate, the AFib correlation, all of those things. So
yeah, I mean, your heart rate variability is obviously all screwed up when you have AFib.
Correct.
Yeah, we call AFib, we call the most arrhythmic of all the arrhythmias.
Yes.
Pardon me if I don't know if that's the same in English. In Spanish, it's kind of the translation. So if you wanna meet one dysrhythmia or arrhythmia that is just, as the doctor from Fred said, all over the place, or how did they tell you about the EKG? It was like
it's all over the place, right? Your EKG, Fred?
Yeah.
Yeah, that's the definition of AFib. And a lot of dysrhythmias can be paroxystical, meaning that they can come and go whenever they want to. So that's the part. More praise for Heather. We're gonna have you more often on the show as well, Heather.
Oh, thank
Just like Jeannie, it's important for the folks to meet the team. Rick Folia is asking about the insulin resistance survey or the insulin response. So insulin should not go above 50. That's for the 1 hour. After 2 hours, it should go back to 40 or less. Fasting should be less than 5. So is that for the 75 grams OGTT or for the 100 grams? So you have two protocols, one where you can do the 75, that's what the World Health Organization recommends, or you can have the 100. To us, it doesn't make that much of a difference. You might expect to see more insulin response on the 100. But the reality is that if somebody has insulin resistance, it's going to have results just like Fred's. So it doesn't make a difference if it is 100 or 120. To us, it's not so much to bring that number down just because. It's more like identifying that you're having an increased response. So for us, the standard, the optimal values are the same independently of the 75 versus 100. And Peggy and Kid Lawson again, CIMT is available at Simon Met, Gilbert, Arizona. So that's interesting. We
I don't think that. I mean, they may know more than I do, but I don't think that's the one that we recommend.
The cardio risk.
That's probably what's going on. I'm not sure what cardio risk is. We always recommend just calling them. And as far as I know, they're only taking patients by phone from Dr. Brewer.
Yes.
So they have their agendas full as well. They have their own patients on their own places. So if you want to get a CIMT from cardio risk, which is the one that we recommend because that's the one that we know it's standardized to provide the information we need. You may need to
because Jesus, just to be clear, they're all called CIMTs, right? It's a matter of what they report.
Yeah, it's different because CIMT is just measuring the inner layer of the vessel, but just by measuring that, sometimes they can report 1 millimeter or 2 millimeters, and that can give you some information. But a lot of cases they don't tell you if that's soft or calcified plaque, and that's what we want to know. Rick Folia, Atlanta Ultrasound does an awesome job on CIMTs for Georgia folks. So that will be interesting to see as well. I mean, I don't think I have ever seen a report from them. So that's the thing. Lung Dog saying lack of HRB is a marker for bad outcomes. So I'll need to do my research on HRB. I don't think I see that too much. I don't know about you, Heather. Do you have experience with HRB?
No.
Me neither. So just so you know, and I would like to put one other comment. This is from a non-YouTube member. This is a comment that I wanted to bring out, and then we can maybe close the show. I hope I can find it. I think this is the one. So Dan Curran says, after my heart attack, I got a stent in the cath lab, as you should if you're having a heart attack. A few weeks later, I got a bypass, valve replacement, and pacemaker. Since then, I lost 150 pounds. Congratulations on that. That's
amazing.
Huge. That's saving your life right there.
Yes.
I would say the losing weight is saving your life even more than the surgery, which except for the stent, of course, which should reduce inflammation in my body. Again, I don't think I have the full information. I would love to hear more about your lifestyle, but I can tell you, bulb replacement and pacemakers are a different beast. Those are a different thing. If you need a bulb replacement, that's important because that is messing up with your heart function. It's not just about the blood flow that goes into your heart, but if you have your bulbs are just too thick that the blood doesn't go through them, you're gonna have issues. If the bulbs are just too, how you will call that, Heather? Like just
they're stenosis, so they're hard and they're not flapping freely like they should.
Yeah, or they are overflapping that they're not closing and the blood just go back again through them. That's the stuff that goes beyond plaque. That's the stuff about the function of the heart. And the pacemaker, there's some scenarios where you need that. When you have dysrhythmias, not necessarily atrial fib but blockages, and a heart attack can cause that. A heart attack can kill some parts or cause that some parts of the heart die, and those parts are important to conduct the electricity that keeps the heart moving. And if you have some of those cells die because of the heart attack, you will need a pacemaker. So that can happen as well. So it seems like this was a really complex issue, and all those intervention. I'll have my doubts about the bypass. Maybe the stent did not work as they thought, and they needed to do a bypass to replace it. I don't know, but lifestyle is going to be important anyway. So valve replacement surgery, pacemakers are different to the whole discussion that we had today, but I wanted you to understand that and do not have the false idea that any heart surgery is not necessary. That's not what we're saying at all. Okay, so any closing remarks, Heather, Fred, before we leave?
No, I think we had a great show and discussion today.
I do think so too. And Fred just kind of refused to give us the benefit of seeing his face for the last minutes, but we
Oh,
appreciate
I'll bring it back.
we appreciate your history.
I was
this-
multitasking.
yeah, as you do.
thank you for sharing your story.
Yeah, and for bringing up those hot questions. Those are important.
Well, I'm going to stay involved with PrevMed, working there, so you can keep me alive the whole time.
Absolutely. Okay, so for the rest of us, the guys who are watching the show, thank you so much. We'll see you next Wednesday.
Thank you.
Thank you.